morning, everybody. It's a pleasure to welcome you all to this instruction course on OCT and OCTA. So, over the last decade, OCT has moved from being a diagnostic tool to becoming a decision-making platform. So, today, biomarkers extracted from these OCT and OCTAs help us not only to diagnose but risk, stratify, and predict the treatment response. I now request Dr. George to start his keynote address.
Uh, Thank you for the opportunity to be here and presenting to you. So I would be touching upon many things on choroidal imaging in pachychoroid spectrum of diseases. So we all know that now it is an ever expanding spectrum from pachyepitheliopathy to CSC, pachyneovasculopathy, PCV, focal choroidal excavation, peripapillary pachychoroid syndrome, and very recently pachyvitaliform maculopathy. So common to all these diseases is presence of reduced fundus tessellation, and you have increased thick choroid in this, generally more than 400 microns, and the classic hallmark of choriocapillary compression overlying a dilated Haller's vessel, and ICG angiography showing a early delayed arterial filling and then areas of choroidal vascular hyperpermeable areas in a patchy fashion. So coming to the first entity, non-specific RP changes, that is pachychoroid pigment epitheliopathy, with or without serous PEDs, and these are considered to be form a frustre of CSCR and mainly in the fellow eyes of CSC. So what you look for is overlying a thick choroid on pachychoroid and vascular hyperpermeability on ICG. You have this autofluorescence showing RP defects and degeneration or RP changes. So this is in the absence of subretinal fluid. Also there are other signs like a pachydrusen or a drusen-like deposits that you see overlying this pachychoroid, and this pachydrusen larger than 125 micron is different from the soft drusen that we see. So these are, the telltale signs of this because it is different from a AMD soft drusen, which is around the fovea. It's collected and overlying a thin or leptochoroid. You have a thick choroid and hyperpermeable choroid, and you see these singly or in pairs distributed across the posterior pole. This is a difference. And then another entity in this scenario is pachyvitaliform maculopathy, where you see this yellowish lesion under the fovea, and OCTA is important to rule out a neovascularization, but the importance is that or the predictive of a pachychoroid geographic atrophy. This is the picture after 6 years, and it goes in for a C-RORA or a pachygeographic atrophy. So this is a case example here. You see this patient who has multiple pachydrusen, and you see these areas of C-RORA. So this again, the other eye. I showed the fellow eye of the patient, but this eye is having a PCV lesion with again a C-RORA. You're looking at a pachychoroid geographic atrophy in this setting. So these images shows the pachychoroid, presence of pachydrusen, areas of outer retinal atrophy and RP atrophy. So this is the kind of these lesions are lesser than the age-related C-RORA or geographic atrophy. The other eye showing RP undulations, double layer sign, and also adjacent areas of geographic atrophy, pachychoroid geographic atrophy. Here you see a leaking PCV, and here you see a geographic atrophy. OCTA showing the branching neovascular network and the polypoidal lesion. So this OCT and a combination of autofluorescence shows this lesion, which can be seen in a plain pachychoroid or associated diseases like PCV, pachyneovasculopathy, or CSC. So this is the atrophy on autofluorescence. So moving to another entity, acute CSC or simple CSC, you have only a neurosensory detachment on OCT. But moving to the and a point leak on fluorescein. But when you move to the other variants like a fibrinous variant or a bullous variant where you have exudative detachment, the OCT signs including hyperreflective subretinal hyperreflectivity in the neurosensory detachment, or a serous PED with a hyporeflectivity. So in this setting, diffuse RPE epitheliopathy, this is a typical chronic CSC where you see the signs on OCT like, intraretinal fluid, a chronic PED, outer retinal photoreceptor elongation that you see on OCT, or even a foveal thinning and ellipsoid zone disruption. These are all poor biomarkers, and especially in the absence of subretinal fluid, you see this large cystic space. This is something called cystoid macular degeneration, poor indicator or poor biomarker in the setting of CSC. These are cases where you have the subfoveal PEDs and on OCT that you see, and subretinal fluid as well, and showing a choroidal vascular hyperpermeability and diffuse leak on fluorescein angiography. So the only effective treatment you see in this serous PED to disappear is PDT, which causes the disappearance of PED as well as subretinal fluid. So around 90% success in our Indian eyes, and as well as compared to the Western literature. So in this regard, when you see another biomarker, that is a acquired vitiliform lesions or AVLs under the retina and between the RPE. So when this is a biomarker that it may not respond well to PDT. This is before PDT and after PDT. After 1 month, there is no response in this case. Another, as I already mentioned, this is a clear-cut case of cystoid macular degeneration, poor visual outcome in these patients. So coming to the choroidal biomarkers, you have either a diffuse choroidal thickening or a focal choroidal thickening. It may just be a focal choroidal thickening, and this thickening can be reversed with photodynamic therapy with the pachyvessel diameter reducing post PDT at 3 months. So another biomarker is something called choroidal hyperreflective foci in the inner choroid as well as in the subretinal space, giving some thought that this is an inflammatory origin in chronic CSC, but in the consensus is that it's an overwhelming choroidal vascular hyperpermeability resulting in cellular and lipoprotein extravasation, causing a hyperreflective foci in the choroid and outer retina. So talking about the focal choroidal thickening, you see this nasal macular choroidal thickening is a hallmark of peripapillary pachychoroid syndrome with overlying intraretinal subretinal fluid. The OCT, this is a classic case wherein on either side of the optic nerve you see this intraretinal subretinal fluid and the macula, and the autofluorescence showing the peripapillary RP mottling and peripapillary pachyvessels and choroidal vascular hyperpermeability. Thus, the importance is that usually in an elderly individual and bilateral situation, so a wrong diagnosis can be avoided. Another OCT biomarker in the choroid is something called posterior choroidal loculation of fluid in CSC, which is seen in around 60% of the eyes with CSC. Spade was the first one to describe a dissociated form outside the pachyvessels and interdigitated form in between the pachyvessels out in the outer part of the posterior choroid. So we had published the first report of this posterior choroidal loculation presenting as a choroidal mass lesion or a choroidal elevation. So these are case examples where there is a choroidal elevation and it extremely thick choroid and the more than 800. So this happens usually when the choroid is overwhelmingly thick, more than 500 microns, and the extra fluid gets accumulated in the outer choroid, saturating the already saturated choroidal stroma. This is a lumpy, bumpy elevation subretinal fluid here. You see, and on treatment on lines of CSC, the choroidal elevation is disappeared. Again, one more patient with a inferior macular choroidal elevation. You see this lumpy, bumpy choroidal elevation, and this is the posterior choroidal loculation of fluid on Swepsour's OCT. And after treatment, it has resolved after 3 months. It's not a choroidal mass lesion. So one more biomarker in very recently using ONFAS OCT, it has been shown that there is intervortex anastomosis in CSC, in the choroid. There is intervortex anastomosis between the superior and inferior vortex vein systems. Normally the horizontal raphe is not obliterated. When you see in CSC, you see this large caliber vessels obliterating the horizontal meridian. This is something called intervortex anastomosis. So ONFAS OCT without ICG can show this choroidal anastomosis, because this gives, especially in complex CSC, it is shown that the choroidal venous congestion happens, vortex vein congestion, and this is happening as a compensatory new drainage route to decongest the vortex vein congestion, and this brings us to the venous overload choroidopathy spectrum, including the bullous CSC and uveal effusion syndrome. Coming to the OCT angiographic findings that has been described in the inner choroid of CSC are dark areas, dark spots, and abnormal choroidal vessels. So these are the dark areas in the inner choroid and choroidal segmentation. Usually it is seen to overlie the area of Pachy vessels and considered to be suggesting inner choroidal ischemia in the setting of chronic CSC. So this could be the pathology in chronic CSC. You have this inner choroidal ischemia and abnormal choroidal vessels in the inner choroid in the form of a ball of wool pattern or an indistinct tangled pattern. These are secondary subtle neovascularization that is picked up on OCTA, but it may be missed on the conventional fluorescent angiography because of the dye leakage, diffuse dye leakage. So this brings us to another type 1 CNVM. This is a de novo, this is not a secondary CNVM, this is a de novo type 1 neovascularization. There is an occult CNVM and a hotspot on ICG, and there is a thick choroid, hyperpermeable choroid, and you have a type 1 CNVM there. This is Pachy neovasculopathy. For example, this was diagnosed as first episode of chronic CSR non-resolving. When you see the swept source OCT, you see the flat irregular PED with a hyperreflectivity overlying Pachy vessels and subretinal fluid. And then when OCTA, this is a superficial deep segmentation, all normal. When you do a sub-RP segmentation, you find this tangled network of neovascularization giving the diagnosis of Pachy neovasculopathy, usually overlying the flat irregular PED. So OCTA is highly sensitive in picking up this neovascularization, whether the first type which we mentioned as secondary CNVM in the setting of a chronic CSU or a de novo neovascularization as Pachy neovasculopathy. So in PCV also the OCT and OCTA combination has revolutionized the serosanguinous maculopathy. ICG used to be the gold standard with hyperfluorescent nodular lesions in the first 1 to 3 minutes, but now we have a non-invasive non-ICG criteria where the three major criteria including sharp peak PED, sub-RP ring-like structure, and a complex RP elevation on on-fast OCT, and along with the other findings of orange subretinal nodule and subretinal hemorrhage and other findings, double layer sign, all these things giving the diagnosis with almost 80% accuracy compared to ICG angiography. And in the revised recommendation, the complex RP elevation on on-fast imaging, because on-fast imaging has to be segmented and difficult for the retinologist, so it has been replaced with orange subretinal nodule on color fundus photography with 85% accuracy, almost comparable to the initial criteria for diagnosis. These are some case images, the classic notched PED with sub-RP ring-like structure, a tall peaked notched PED, or a thumb-like PED, or you have a double layer sign with separating the RP from the Brooks membrane. So also these patients can have serous PED. So serous PED is on ICG showing a polyp at the inferior edge of the PED, but then these are not CSC PEDs. This respond well to after switching to aflibercept injection. So it has to be kept in mind that serous PEDs like this or with a notch PEDs can have coexisting CSR in one area and inferior polypoidal lesion, because both belonging to the same spectrum of diseases, the pachychoroid disease spectrum. So again, one more OCT finding is a hemorrhagic PED with a intraretinal hyperreflectivity and back shadowing. So this is a hemorrhagic PCV. So if the subretinal thickness of the blood is less than 400 microns in the study conducted showed that with intensive anti-VEGF monotherapy without gas displacement can have good vision like this if treated early. So OCTA can very well pick up the branching neovascular network. The polypoidal lesions are not greatly picked up because they are low flow lesions compared to the ICG angiography. So because many clinics lack ICG and PDT currently, so we could combine OCT and OCTA and then go ahead with intravitreal monotherapy, and then the PDT rescue and ICG can be reserved for persistent polypoidal lesions. So the last entity is focal choroidal excavation which is a sharp excavation in the choroid with or without attached neurosensor retina. This is a non-conforming type, this is a conforming type, but the importance is that these patients could harbor neovascularization, and it requires only a few injections for these to respond very well in the pachychoroid spectrum of diseases. So to summarize, so it is important to understand the imaging criteria of pachyepitheliopathy because these patients can develop CSC, vitiliform maculopathy because they need very careful follow-up. They can proceed later to pachychoroid geographic atrophy. CSC with the swept source OCT, the various phenotype as well as the disease mechanism is being unraveled now. And the chronic CSC and the peripapillary pachy syndrome, the half-dose PDT is the current gold standard as we saw in some of those patients. Pachy neovasculopathy, secondary CNVM and FC related CNVM, OCTA is very important because the conventional angiography sometimes may miss it. And PCV, it's a non-invasive imaging criteria now, anti-VEGF monotherapy, and ICG and PDT reserved for persistent polypoidal lesions. Thank you.
Thank you, George, for that excellent talk. Our Paki man from India. George, I have just a few questions for you as Dr. Harshal is getting ready. One, is there any biomarker which points out to the fact that this is a PCN, a pachychoroid neovasculopathy? One. Two, do biomarkers help us to decide which is the anti-VEGF of choice, for example, in the setting of PCV? And third is pachychoroid, peripapillary pachychoroid syndrome. What is the treatment of choice?
So, as I already mentioned in the talk, actually, the PCN combination of OCT and OCTA is very important because the presentation is almost the same like the case which was referred, only a referral for PDT in the setting. But then when we image with an OCT and combination of OCTA, it turned out to be a neovascularization. So that is very important. So it may be in the absence of any history of CSC also. Patient could just present with the first presentation. It need not always go from pachyepitheliopathy to CSC, then to PCN, and no. Patient can present directly in the setting. So it's very important to combine. So that was the first question. And then, so for PCV actually now in the age when we had only the ranibizumab and Avastin, it has shown that the polyp regression or the treatment success. Now how do you define treatment success is nowadays, because it's OCT criteria, people look at injections and say that macula is dry, and that is what we call as polyp inactivation. But then that is a pseudo feeling of success. But then you have to look at the polyp closure rate, because when it has been studied over 2 to 3 years, the recurrence and rebleed and loss of vision is very high. So that is why it's important that these patients at some point so it need not be in the first 6 months, but at some point we have to look at where the polyp regression is there. So now it is anti-VEGF monotherapy. We have much better anti-VEGF. For example, we have aflibercept, or now even brolucimab, or now the faricimab has shown almost 60% with the. So it is very important to have loading doses, and the treatment success is much more. But then we need to re-evaluate it after 6 months. Any of these patients undergoing treatment, initially the loading doses, and then once you stop, you need to re-evaluate whether it's only an inactivation or is it a real thing. And the last question, which peripapillary pachychoroid syndrome is a variant of CSC, and usually, as I showed images, it's important to diagnose. So this is one condition wherein none of the other treatment modalities work actually. If you try focal laser or epilineron or any other things, it doesn't work. The only thing that has shown to work in our hands is photodynamic therapy.
Thank you, Dr. George. I think we'll move on to the next talk. Dr. Harshal will be talking to us on biomarkers in neovascular AMD. Dr. Harshal.
Good morning, everybody. So before we actually go to the OCT biomarkers in neovascular AMD, let us understand the newer nomenclature, where type 1 is the sub-RP MNV, type 2 is the subretinal. You can have a mixed variety, and the type 3, which is the RAP. So type 1 is basically when the membrane is under the RP, and it's more likely to maintain vision over time. Because these vessels are nourishing the outer retina, there's a less risk of developing geographic atrophy. However, it requires more anti-VEGF injections as compared to the other types, and you could have recalcitrant or sub-persistent fluid. The long-term visual outcomes are typically better. The type 2, where the membrane is above the RP, results in more of a fibrotic scarring as compared to the other MNV type, and that in turn results with a poor visual outcome. However, it responds faster to the anti-VEGF. The type 3 or the RAP is associated with higher rates of geographic atrophy and leptochoroid and retinal pseudodruseness. Very important that they may have the similar pathology in the fellow eye. So if you look at the OCTA, you'll see flow. In the type 1, you'll see flow under the RP. In type 2, you'll see flow above the RP. And in type 3, you'll see the flow coming in from the outer deep plexus to the outer retina. So coming to non-exudative macular neovascularization, this is typically seen in patients where we are treating the other eye exudative MNV. So double layer sign, as Dr. George explained, you have this separation of the RP from the Brooks membrane. And Narita et al. Described when the length is more than 1000 microns, it could be harboring a MNV. So this is a case where clinically you don't see anything much. OCT shows just the double layer sign, but an underlying OCTA will show you a non-exudative MNV. Activity clinically, we have known that it is fluid, heme, and mixture of heme, fibrin, and exudate, what we now call as the SHREM. The location of MNV obviously has impact on the visual acuity. You'll have better visual acuity with the extrafoveal and juxtafoveal as compared to the subfoveal. Central subfoveal thickness is a biomarker. It has been used as a criterion in many drug trials, but wherein you consider less than 25% reduction as a criterion for reinjection, but it cannot be used in isolation because visual acuity would then depend on the fluid and the SHREM. In cases of geographic atrophy, a lower subfoveal thickness would actually indicate lower visual acuity. So distribution of fluid is one of the major biomarkers. If you have intraretinal cystoid fluid, it's associated with poor baseline visual acuity as well as poor visual recovery after the anti-VEGF treatment. It's associated with a higher risk of visual loss and development of fibrosis and atrophy. It need not be an exudative fluid, as Dr. George mentioned. You could also have degenerative cystoid spaces. Subretinal fluid is the exudation which occurs between the outer border of the photoreceptors and the RPE, and it's a better biomarker as compared to the intraretinal fluid. It's the most frequent fluid localization that you see in type 1 MNV, and refractory SRF may not have a negative effect as we saw in the fluid trial. PED is the separation of the RP from the inner collagenous layer of the Brooks membrane, and less important for the visual prognosis. You could have a serous drusenoid, fibrovascular, or a hemorrhagic PED. Coming to RP tears, these are the most feared complications in neovascular AMD, which can happen either spontaneously or even as a result of treatment. And the factors which predispose are the large diameter of the PED, the increased vertical height, and the duration of the PED. Subretinal hyperreflective material, or the SHREM, is the hyperreflective material that you see between the neurosensory retina and the RPE, and it persists even after the anti-VEGF treatment. OCTA would help us differentiate from the vascular and the avascular components of the SHREM. Photoreceptor layer integrity, if you see the disrupted external limiting membrane and the foveal EZ band, that is associated with compromised BCVA at baseline and despite treatment. Hyperreflective dots are these well-defined circumscribed lesions that are around 20 to 40 microns, and these are actually the lipid-filled microglia cells. There is a persistence of high number of these HRDs in the non-responder patients. ORT are these hyporeflective surrounded by a hyperreflective band, and these are the rearrangement of the photoreceptors and indicate poor visual prognosis. The anti-VEGF treatment does not decrease the development of newer ORTs, nor does it regress the older ORTs. So you can see ORTs in different stages of evolution, one where it has fully developed and one where is it in progression. Coming to OCTA, it yields new insights into the physiological and pathological blood flow of the retina and the choroid. It's non-invasive, the examination time is short, it provides a more broader and detailed picture about the morphology. It's possible to visualize and monitor subclinical non-exudative MNV as we saw in the first case, and these images can actually be translated into mathematical descriptions. So based on the morphological shape, you can have a C-fan, a medusa form, or a glomerular form. All these forms indicate an active CNV. Whereas these long linear vessels where there are no capillary ramifications, these are like a dead tree pattern and resemble the mature vessels which respond poorly to the anti-VEGF. The other biomarkers are the vessel termination, again the branching vessels, the vascular loops and the anastomotic arcade along with this halo again are an indicator of an activity and tend to be treated. The Skalsbergs described these loose nets and dense nets. Loose nets were again these mature vascular lesions, whereas dense nets had higher proliferative activity and responded to the anti-VEGF. There are several other quantitative biomarkers and which can be combined with AI to show us the prognosis over time. This can be integrated in a AI dashboard, and then you can actually predict the outcome and the required treatment frequency. So this is all under current research. With this, I end my talk. Thank you.
Yeah, continuing with this trend of newer nomenclature. Now we are as retina specialists, we are very fond of newer acronyms. So continuing with that trend, now I'm going to introduce you to some more terms here in this talk. Anyway, my talk is on OCT and OCTA biomarkers in retinal vascular occlusions. Now we all know that retinal vascular occlusions are major causes of visual loss, and they require timely diagnosis and management. Now, until recently, clinical findings and angiographic features, they were used to prognosticate and treat these patients. Now, the advent of OCT and OCT angiography, this is revolutionary the way in which we manage these diseases presently. Now, what are the information that you look at? Now, basically, we are trying to look at the macula, which is just a manifestation of the response of the retinal vein occlusion or the retinal arterial occlusion. And we are trying to look at these various features on the OCT. Increased retinal thickness. We are looking at fluid, intraretinal fluid, and subretinal fluid. We are also looking at hyperreflective foci within the retinal tissue. We are looking at vitreoretinal interface changes. We are trying to see how the inner retina is, whether it's opacified. There could be disorganized retinal inner layers, which is called as drill. You could also have disorganized retinal outer layers like loss of ellipsoid zone. So all these are the factors that we look at when in an OCT, and some of these help in prognosticating patients. Now some of the data that I'm going to present today is from a publication that we published some time ago on retinal vein occlusion. So baseline CFTs. Baseline CFT is an important predictive factor for anatomical and visual outcomes, and this has been established across various studies. But in reality, it is not an excellent tool because it's quite variable. Because a lot of other factors come into play when you want to interpret this finding alone. There is data from the SCORE and from various meta-analysis. It kind of persists. Then across BRVO and CRVO, it has been established that these eyes have poor visual and anatomical outcomes. Now there is a sign which is called as a prominent middle layer membrane, which is mostly seen in CRVOs. And maybe in ischemic BRVOs also, but it denotes increasing ischemia. And this is due to the intermediate capillary plexus and deep capillary plexus ischemia and the adjacent bipolar synapse edema. So this is a poor prognostic marker if at all you happen to see this in your patient. Paracentral acute middle layer maculopathy is a focal area of middle layer opacification that you can see on the OCT. These, again, if present, can be a poor prognostic marker because this is often associated with deep capillary plexus ischemia. Now, one needs to differentiate whether this opacity, middle layer opacity, is very focal, like in PAM that we described before, or is it a diffuse kind of a middle layer opacification? If that is so, then you need to think of an associated arterial occlusion because this is more common in arterial occlusion. So, is OCT really useful in CRO? Do you need to do an OCT in CRO? There is a recent classification which has classified CRO into mild, moderate, and severe based on the reflectivity in the, of the different layers and loss of stratification. But we did our own analysis. We found that it was not really useful. There was no correlation with visual acuity, either at presentation or at the final visual acuity. But we did identify some other findings which may be of significance, like the presence of the prominent middle limiting membrane that you see in the white arrow. Now, this is a good prognostic sign when you think of CRAO. It is a bad prognostic sign for vein occlusion, but for CRAO, it is a relatively good prognostic sign because once you see that, the ischemia is lesser in these patients, and these patients may do excellently well, as you can see in the final follow-up. Again, in the right side pictures, you see in a severe ischemia, you don't see the prominent middle layer membranes. Then there is also the concept of reperfusion. Most of the patients, when they come to us, they're kind of reperfused by the time they report to us. So there are some evidence of reperfusion in these CRAO eyes. These findings, like presence of intraretinal fluid and subretinal fluid, is now believed to be due to breakdown of blood-retinal barrier as a consequence of reperfusion. Also, ILM detachment has been reported, which is again a feature of reperfusion. So all these are bad prognostic markers. If you see a CRAO patient which has got intraretinal fluid and subretinal fluid or an ILM detachment, these patients are generally bound to do badly. Again, NFAS OCT is also useful. Sometimes you see this kind of a pattern, a fern leaf-like pattern. When you see these patterns, when you happen to see them, these are better prognostic signs as against the globular pattern, the banded pattern that you see in the lower pictures. OCTA has revolutionized the way in which we look at retinal capillaries. We know that FA is not enough now because it's two-dimensional. With OCTA, we can see 3 layers of capillaries, and we love seeing all these 3 layers and studying them when we see patients with macular edema. Like in this patient, you see there is a lot of leakage at the macula on angiography. You cannot sometimes make out whether it's macular ischemia or not. But look at the OCTA, you can very clearly make out that there is significant ischemia. There is FAZ is widened. So now we have macular ischemia, and now we know that this is a bad prognostic sign. Now with the SS OCT that we have, we get spectacular images. It just shows us the extent of ischemia that these patients have. Now consider this patient. This patient improved structurally on the OCT, but the visual acuity did not improve. We did an OCTA. This is the superficial capillary plexus. You see a nice FAZ. You also see the collateral there. It seems that this patient should have got good visual acuity. But if you look at the deep capillary plexus, you can see that there is ischemia. So there can be a selective loss of capillaries in one of these layers, and this can explain why some of these patients, they don't do well after anti-VEGF therapy. Now, OCTA is also useful to pick up abnormal new vessels, which can be missed on a casual examination. Like in this patient, there is a posterior pole new vessels. And we now routinely do ultra-wide field OCTA because we now understand that the mid-peripheral ischemia is an important risk factor in these patients. And this may be missed on a conventional fundus fluorescent angiography. And we can get very wide field OCTAs now. This is the superficial capillary plexus and the deep capillary plexus, very easily studied in these images. We can also map the area of ischemia. The machine gives the fluid void area, and you can calculate the ischemic index. We now know that ischemic index is an important biomarker for increasing ischemia and conversion, for example, of a non-ischemic CRVO to ischemic CRVO. So gone are the days where we just used to traditionally look at the macula. Now we have wide field images. We can pick up more information, new vessels, CNP areas much more vividly in these machines which can do 29 to 29 millimeter wide field images. This is a patient with a wide field image showing collateral, showing good perfusion. We know this patient will do very well. So collaterals are important. When now studies have shown that collaterals are seen much early. We used to think that they appear by around 3 months. It's not so. The collaterals start forming right from the time of the occlusion, and this has been shown. And these patients have good resolution of macular edema. Various types of collaterals have been described. And there are a lot of OCTA-based metrics that we use: decreased vessel density, decreased fractal dimension, increased FAZ. All these are biomarkers which tell us that this approval. We now try to compare the deep and the superficial flow rates, and if the ratio is lower, we know that this is an eye which is progressing towards more ischemia. We look at the ischemic index. We have a value now 30%, more than 30%. It means increased ischemia. We look at the collaterals. So all these are poor prognostic markers. These patients may end up with persistent macular edemas and increased anti-VEGF burden. Now in CRAO, OCTA's role is very limited. It helps us to understand non-invasively, a quick glance, to know whether the patient is actually reperfused or not. Like you can see these images, the patient is grossly underperfused here. But sometimes when you have a perfusion, it helps us to understand why some of the CRAO patients have good vision and while others don't have. Here you see that the cilioretinal artery seems to have perfused the deep capillary plexus. But you see in the first, on the left side, you see the visual acuity is poor because the foveas is involved, is not perfused by the deep capillary plexus. Whereas on the right side, you see it is perfused. So it helps us to understand why some of these patients have good or poor vision. But the most important caveat is this, that these patients have poor vision, so the fixation is going to be bad. You're not going to get excellent images that I showed. This is like a day-to-day practice image. This is how you get the images. So you have to be aware of these artifacts. There could be shadow effects, projection artifacts, segmentation errors. So you have to interpret all these findings, putting your clinical skills also into practice. So to conclude, OCT and OCT angiography provides structural and vascular clues that can predict visual and anatomical outcomes. We now have identified certain key OCT biomarkers and OCTA-based biomarkers which help us predicting visual outcomes and helps in decision making while treating these patients. Thank you.
Thank you, sir. So how difficult is it to get a wide field OCTA in a busy OP? I mean, is it you just click and the whole wide field comes? Because with the montage, it's extremely difficult.
No, one thing is now when some of the machines have the capability to give you a wide field, like the machine that we have. The Interlight is SSO Octa, which is a 4 megahertz processor. So it's very fast. It can, that it is not really beneficial. But my point is that there is no harm. Now, when you have a patient with persistent macular edema, and you have tried out your anti-VEGF or switch to steroids, and they continue to have some kind of a mid-peripheral ischemia, there is no harm in doing laser. And then, because I think anecdotally, I think most of us have seen patients who have improved a bit. So, but based on trials, no.
No, but in a very important point that in diabetic retinopathy studies, it has shown that it is not targeted laser to the peripheral ischemia. But here there is one more important aspect, as you said, the ischemic index. Now more than 10 disc areas were considered in CRVO study, which is no longer acceptable when you have ultra wide field imaging. It has, you see not 10, 100 disc areas also, it can be so extensive. So these not only for the macular edema regression, of course, what you said makes a lot of sense, because there is no harm in treating this peripheral, especially, and also the ischemic conversion happens very high in these patients. Patient going for a rubiotic glaucoma and NVI. So it's very important to pick this, the ultra wide field Octa. Now especially the Plexelite of the Zeiss is no more available. But I think Interlight and other imaging machines, especially in vein occlusion, it is very important, because without a dye-based angiography, you can see the extent till aura of ischemia, which is, even if ischemic conversion or treating a neovascularization, you need to see the real extent of ischemia before treating actually. Also, one point which Manoj said of prominent middle limiting membrane, but it is seen in both CRAO and CRVO. But then there is a, that is just based on OCT. Now there is a classification based on combining OCT, ONFAS and the OCTA, wherein this prominent middle layer corresponds to the perivenular kind of PAM on first and middle layer ischemia on. So in a CRAO kind of setting, that is the most subtle variant. You see a perivenular or a diffuse PAM on first OCT, and you see a middle layer ischemia corresponding to the prominent middle hyper reflective. That is a more subtle form of central retinal artery occlusion without an clinically evident CRAO. Patient has subtle drop in vision. So that is called OHM1, oxygenation based hypoperfusion maculopathy type 1. Type 3 is the full blown CRAO with inner retinal hyperreflectivity. So it is graded as a more subtle form only involving the middle layer in the cross section, and then involving towards the anoxic retina towards the internal limiting ganglion cell layer. So combining these three will give and in CRVO without macular edema, if there is abnormal vision, it's very important to pick up that sign, because that will be the only sign of macular ischemia actually.
Only one last comment is that no, it's not that the prominent middle layer sign is not seen in all CRAO patients. It should be seen, but it's more evident in the milder varieties because there is a contrast between this reflectivity and the adjacent reflectivity. Whereas in the severe ones, it's so opaque that no, you don't see it. So that way, this is a good prognostic sign, because it tells you that no, you're dealing with a milder form of CRAO which is likely to resolve better.
Is there anything that we can do at this stage?
We have actually in the publication where it can either resolve with a almost subtle or thin without thinning, or it can progress to full blown CRAO. So if you pick it up and treat with antiplatelets and I think one patient we have actually heparinized also, came back to see from 6/9, it came back to, it can within a week it can go for full blown arterial. In fact, David Saraf and group recommends if you see this to go for an antiplatelet therapy.
I now request Dr. Sharath Ravi to present his talk on OCT biomarkers in diabetic macular edema.
I'll be talking on diabetic macular edema, how OCT helps in imaging. Diabetic macular edema is one of the most frequent cause of a reading vision loss, and most of the patients with more than 20 years of diabetes, almost 1/3 of these patients have some form of diabetic macular edema. So this was one of the diabetic patients who came to a retina OP for a routine fundus examination showing a non-proliferative diabetic retinopathy. There is no obvious macular edema, but on taking the OCT, you have a center involving edema which required anti-VEGF therapy. So why is OCT important in DME? Because it's more sensitive than a clinical examination in picking up subtle edema, as well as it is non-invasive, non-contact. The resolution is very high, so you have the structural changes visible very clearly. You can pick up interface abnormalities, and based on this, you have the treatment options, assess the response to therapy, and plan your retreatment. So in the era of OCT imaging, we have been introduced to this concept of a center involving and a non-center involving edema. So what is a center involving edema? It is a central subfield thickness of 250 microns, or edema within 500 microns of the center of the macula, or any edema more than one disc area within one disc diameter of the macula. So in other words, it's a blend of earlier clinical significant macular edema with OCT parameters. So in diabetic macular edema, you could have any of these patterns, and a spongy edema is a diffuse thickening of the retina with hyporeflectivity at the outer plexiform and the inner nuclear layer, and usually you have a good response to treatment. Whereas in cystoid edema, you have the fluid accumulated within well-defined spaces in the outer plexiform layer, and based on the size of the cyst, they could be small, large, or giant cysts, and the larger cysts are associated with macular ischemia. So what determines the visual acuity is not just the presence or absence of the cyst, but it is the number, the size, and the location of the cyst, and also the amount of the residual foveal tissue. So if you look at these cystoid process, sometimes there could be bridging retinal processes which are vertically oriented hyperreflective lines, and these lines actually connect the inner and outer retina, and these are a positive biomarker. So whenever you have these bridging retinal process, it indicates you have a better visual response following therapy. An absence of bridging retinal process, it usually indicates a poor prognosis even following therapy. In a cystoid degeneration, sometimes you could have a prominent foveal cyst, and this is causes reversal of foveal contour, what we describe as a foveal eversion. And this foveal eversion is one of the biomarkers for a poor response to anti-VEGF therapy and also rapid recurrence following the therapy. And some cystoid processes may have hyperreflective material within them, and complete occupancy of these hyperreflective material within the cyst usually is due to a long-standing edema and indicates a poor prognosis, and also patients with ICHRM have a poor baseline visual acuity. The other type of macular edema is a serous retinal detachment. You could see where there is a hyporeflective space behind the neuroretina. It usually correlates with disruptions in the external limiting membrane, and most of the studies showed that patients with subretinal fluid usually have a better response to treatment, and there is an increase in inflammatory mediators in these patients, and they respond better to DEX implants. A subset of patients may have vitreomacular interface abnormalities, which could be either a frank VMT or a taut posterior hyaloid, and these patients do not do well with medical management alone, and they need surgical intervention in the form of vitrectomy and ILM peel. And this is one such patient with diabetic macular edema along with epiretinal membrane, underwent combined phaco with vitrectomy and removal of the ILM and the epiretinal membrane, and these patients do reasonably well when this vitrectomy is combined with your anti-VEGF or with the intravitreal DEX implant. More often you have a combination of patterns, like a combination of cystoid edema and neurosensory detachment in this patient. So OCT helps to identify specific biomarkers that are important in identifying the baseline visual acuity as well as the visual response to therapy. And the earliest used biomarker was the central subfield thickness. Like Dr. Manoj told, the central subfield thickness is the retinal thickness that is computed in the central 1 millimeter zone. And how good is it as a predictor of best corrected visual acuity? The protocol A study of the DRCR network showed that at the best there is a modest central subfield thickness alone is not a good or accurate predictor of the best corrected visual acuity. The other biomarker is the disorganization of retinal inner layers. It's a disorganization of the inner retinal layers, like the inner plexiform, the ganglion cell layer, the inner nuclear and the outer plexiform layers. How to identify it is you start tracing the inner retinal layers towards the fovea, and where the borders between the layers get indistinct, drill is present. And when the horizontal extent of drill is measured in microns, and when drill occupies more than 50% of the central 1 millimeter zone, it is supposed to be associated with a poor visual acuity, and it is often seen in severe forms of diabetic retinopathy associated with loss of outer retinal layers as well, and usually has a poor visual prognosis. Like in this patient where drill was present, even though the anatomical response to the anti-VEGF therapy could be good, your visual response is suboptimal. The hyperreflective foci, it's seen in most vascular conditions, also seen in diabetic retinopathy. You have these distributed mostly in the inner retinal layers, and their size is less than 30 microns, and the reflectivity is similar to the nerve fiber layer. They are biomarkers of retinal inflammation, and these patients do better with steroid implants. And also, if a patient has more hyperreflective foci at baseline, it indicates a more active form of DME and a poorer response to treatment. So to differentiate it from hard exudates, the hard exudates are larger, more than 30 micron size, located in the outer retinal layers with with the back shadowing, and reflectivity is similar to the RP Brux layer. So hyperreflective foci could be also present in outer retina when there is a disruption of the external limiting membrane or the ISOS junction. They could be present in choroid, and it is indicative of a poor prognosis, and also in severe forms of diabetic retinopathy like a proliferative diabetic retinopathy. In a long-standing edema, you can have a pearl necklace sign, which is the arrangement of hyperreflective dots in a linear pattern on the inner wall of the cystoid process, and usually they leave behind visible hard exudates and rarely disappear completely. And it's seen in when subfoveal in location, they are associated with a poor prognosis. The outer retinal layer continuity is another biomarker that has got prognostic significance. You look at the external limiting membrane, which is actually the plexus between the Muller cells and the photoreceptor cells. And whenever the external limiting membrane is disrupted, fluids start entering into the outer retina. And these disruptions in the external limiting membrane are associated with disruptions in the ellipsoid zone. So ellipsoid zone is nothing but the photoreceptor layer, and percentage disruption of the ellipsoid zone has got prognostic significance. And therefore, patients with the disrupted ellipsoid zone have a poor visual acuity, and on a timeline, the ELM disruptions occur earlier than the ellipsoid zone disruption. The choroidal thickness can be measured either by a manual method or by an automated image processing, the mean choroidal thickness being lesser in patients with DME. And if your DME patient is having a thicker choroid at baseline, it indicates a better response to anti-VEGF because of a more intact choriocapillaries and less of outer retinal ischemia and a better preserved photoreceptors. So the other biomarker is a parallelism. You have the outer retinal layers parallel to each other in a binarized image of the OCT, and in a DME patient with large cystoid spaces and hyperreflective foci, you find that the outer retinal layers are not well identified, and so therefore the binarized image is not able to produce any degree of parallelism of the outer layers. And loss of parallelism is associated with a poor visual acuity. OCTA is important in diabetic retinopathy as it identifies disease in the preclinical stages. Like you have increasing FAC disruptions in the superficial capillary plexus, focal microaneurysms in the deep capillary plexus. And as one progresses from the no DR to the PDR stage, you have an increasing FAC dysmorphia as well as increasing diabetic macular ischemia. And this important study by Lee and group published in Ophthalmology in 2016, you showed that the poor responders to the anti-VEGF therapy usually had a greater loss of the deep capillary plexus, not so much so in the superficial capillary plexus at the baseline. And these patients who have a greater loss of the deep capillary plexus, they have a corresponding outer plexiform layer disruption as well. The other biomarker is the macular vessel density. You have the vessel density measured through metrics like vessel area density or vessel length density, and it's reduced in both superficial as well as the deep capillary plexus. So it's a negative biomarker indicating a poor prognosis if the vessel density is reduced. So OCT is an integral tool to diagnose, classify, and to prognosticate DME and identify which agent to start your treatment, assess your response to therapy and identify the poor responders, and also to take decisions on retreatment and switching between agents. And it also helps to identify patients who need a surgical intervention. And OCTA has got a promising role by identifying disease in the preclinical stages and also identifying poor responders. Thank you.
Now request Dr. Manoj to give a memento to Dr. George. I thank you all for attending this. One last question. When do we expect that the AI would sit in the OPD and tell us what to inject and when to call the patient next? In how many years?
We don't want AI is going to help us, especially I believe in diabetic retinopathy, most important thing is screening. You don't need a doctor to screen actually. So those patients will come to you for treatment. So now AI enabled cameras have already come. So that is a primary, I think, the role. And then AI enabled OCTs will come and it will show that, which needs treatment, which do not. I think it's going to aid us rather than replace us.
I think one more point about AI is we have to be strong to give the ground truth. So unless we are going to give that information, the ground truth is very important whenever you plan a AI thing. And for an Indian eye, I think that may not be existent. So I think it's beyond our time.